Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Greetings, everyone. I'd like to welcome you to our Medscape Oncology Navigating Advances in TRK Fusion-Positive Cancers, a collaborative journey from testing to therapy. I'm Jonathan C. Trent. I'm a professor of medicine at the Miller School of Medicine and the director of sarcoma oncology at the Sylvester Comprehensive Cancer Center at the University of Miami in Miami, Florida. I'm delighted to introduce our other speakers, Dr. David S. Hong, who will be discussing clinical updates in TRK fusion-positive cancer treatment, and Dr. Theodore Leitch, who will be discussing partnering with patients and caregivers. Our first chapter is personalized planning through molecular testing. We have to start by understanding TRK receptors and how they mediate neurotrophin signaling. Neurotrophins are important growth factors that promote sympathetic nervous system development. Neurotrophin signaling occurs through activation of the TRK receptor family. These are composed of TRK-A, TRK-B, and TRK-C. These have various functions and natural ligands that you can see at the table on the left. Importantly, these ligands bind to the receptor through tyrosine, resulting in kinase activity and activation of downstream molecules such as ERK and AKT. The biology of TRK is critical in cancer development because these TRK molecules can also result in fusion proteins. These are some examples of TRK fusion genes at the top left of this slide. And these are present in a variety of different cancer types as critical oncogenes that lead to carcinogenesis. Thus, TRK fusion results in an oncogenic driver that has the potential to turn a normal cell into a cancer cell. Now, if you look over on the right is a molecular cartoon showing the 5' gene partner, which can be a number of different genes, fused with the 3' TRK kinase domain. When this fusion takes place, RNA is made, protein is translated, and results in constitutive activation of TRK signaling. The TRK molecule can bind to IRS1, SHC, GAB1, and result in downstream kinase activation of PI3 kinase, AKT, which drives survival and prevents apoptosis. On the other hand, TRK fusion also results in activation of the RAS pathway via GRAB2, SOS, RAS, RAF, MEK, and ERK, leading to uncontrolled growth proliferation. For instance, on this slide, you can see on the left all of these different types of adult cancers that can be driven by an NTRK fusion, such as glioma, such as thyroid and head and neck, sarcomas, leukemias, even the liquid tumors, renal cell colorectal melanoma, GI stromal tumor. It can be very common also in secretory breast cancer, other breast cancers, pancreas, and other GI cancers. Additionally, TRK fusion cancers occur in childhood cancer, and these are some example of the pediatric cancers such as brain tumors, thyroid cancers, sarcomas, secretory breast cancer, infantile fibrosarcoma, a rare type of sarcoma, and the congenital nephroma. So a little fewer entities, fewer anatomic distribution, but these can occur again in many different places in the body, and children can be difficult to diagnose because cancer is so very, very rare. So on that topic, let's talk about some diagnostic strategies. These are some of the methodologies that are used globally, really, for NTRK fusion gene detection. So, one of the simplest methods is immunohistochemistry. This helps us identify if TRK is present at the protein level. It'll tell us whether TRK is there or not, but is not has some limitations in terms of confirming a translocation. Now, fish can tell us often if there's a translocation, whether TRK is in the right location or the wrong location. RNA-seq NGS, next generation sequencing, is thought by many to be the gold standard because the TRK fusions at the RNA level can be detected across the fusion, and the fusion partner can be identified along with which TRK of the three TRK genes is fused. DNA-seq can also be useful, although some limitations, as we'll discuss. So we consider immunohistochemistry to have moderate sensitivity, but some specificity in terms of the TRK, the presence of TRK at the protein level, not necessarily the translocation. Fish is much more sensitive and specific and tells us whether TRK is a partner in a translocation, but doesn't necessarily provide the translocation partner. RNA-seq NGS provides the highest sensitivity and specificity in that it can tell us not only whether there is TRK fusion, but can also tell us the translocation partner for TRK that is driving the oncogene. Now, RNA-seq NGS takes the RNA that has already been transcribed from DNA, and so all of the introns are taken out, and the RNA can be looked at and sequenced across the translocation. DNA-seq has moderate sensitivity in that some fusions have been missed in the past. DNA-seq is a lot better now than in the past, but there were concerns raised by certain investigators and authors of manuscripts that there might be some limitation with the DNA-seq in terms of sensitivity. But when you detect it, it's very, very specific. Now, additionally, the detection of all fusion genes can be performed with IHC, FISH, RNA-seq, and DNA-seq if the resources are put into it, especially for the NTRK, okay? Now, when we talk about the detection of the fusion partner, IHC and FISH don't detect those, whereas RNA-seq and DNA-seq have the capability to detect both TRK and its fusion partner. Very important in our treatment paradigm. FISH does not detect expression, it detects the DNA. RNA-seq does detect expression at the RNA level, so it will tell us whether the translocation has occurred and whether it has been transcribed from DNA into RNA. It doesn't necessarily give us 100% certainty in terms of protein, but it's generally accepted as the gold standard for expression. Now let's talk about the recommendations from ESMO in terms of detecting these fusions. So the European Society of Medical Oncology developed this algorithm in 2019 to discuss how to test for TRK gene fusion. And so the sample is obtained, and the first question that's asked of the pathologist is whether this histologic tumor type is known to harbor a highly recurrent NTRK fusion. So, if an NTRK fusion is known, for instance, in an infantile fibrosarcoma, then this tissue will use FISH, RT-PCR, targeted RNA NGS to detect for specific probes for the fusion involving the known NTRK gene. If this is a cancer type where NTRK is very rare, for instance, then you might consider ask determining whether there's a sequencing platform that's available, and if there is a sequencing platform that's available, using frontline NGS to detect NTRK fusions is preferred, including RNA testing, like we discussed, RNA-seq when possible. If it's a situation where sequencing by NGS, RNA-seq, DNA-seq, these are not available, then one could use IHC as a screening tool. And there may be no TRK expression, or there may be TRK expression. If there is TRK expression, this suggests the possibility of a TRK fusion. It doesn't confirm it with 100% certainty, but if there is TRK on immunohistochemistry, that would recommend testing by RNA-seq when those resources are available. And so additionally, there are some patient-centric practices to consider, such as patient education around the disease biology. Testing options is key to shared decision-making. Patients should understand the goals of testing and potential outcomes if an NGS or other test is positive or negative. Some tests also, some of these NGS tests, DNA-seq, RNA-seq, may find germline mutations. If that is detected, then we generally recommend referral to a medical geneticist to help manage that specific situation. Well, I'd like to thank you for your time today, and thank you for participating in this important event that is really a new treatment paradigm for patients with NTRK fusion cancers. And hope you enjoy the following speakers. Thank you very much.
Hi, I'm Dave Hong. I'm the professor and deputy chair of the Department of Investigational Cancer Therapeutics at MD Anderson Cancer Center. I'm here to talk about Chapter 2, the clinical updates in TRK fusion positive cancer treatments. This is the trial that eventually led to the first approval of the first NTRK inhibitor, larotrectinib, in NTRK fusion positive solid tumors. I was lucky to be a participant of this trial. We pooled really three groups of patients, adult phase 1s, the SCOUT pediatric, and the Navigate adult adolescent phase 2 basket trial to accrue close to 55 patients on this study. And based upon the initial results, which again showed that across tumor type, age, NTRK gene, or fusion partner, that the response rates remain very, very high, and FDA allowed for the first small molecule tumor agnostic approval. Overall, the study showed that these drugs, these NTRK inhibitors, have been very well tolerated. The vast majority of adverse events were both grade 1 or 2. Fatigue, some nausea, and dizziness were the most frequent. The most frequent grade 3 adverse events was primarily related to anemia in some sense and ALT/AST increases. Early on, we weren't recognizing that these drugs can also affect weight, and we were seeing there have been some patients who have had some significant weight gain based upon these NTRK inhibitors. This was one of the more recent pooled analysis that we looked at, now accumulated close to 240 patients on the Navigate basket study. And as you can see here, the response rates remain pretty remarkable. Overall response rate close to 75%. And again, this expanded data set beyond the 55 show the power of these drugs, particularly in NTRK fusion patients. Again, the duration response is remarkable, close to 43.3 months. I've had patients who are, I still have a patient who's on the phase 1 trial, who's still on the study almost a decade after he started the study. So these drugs can have durable responses and benefit. You can see here, again, from the pool analysis, median duration of response, 43 months, median PFS, close to 30.8 months, and overall survival has yet to be reached. Um, we recently looked at ESMO the efficacy and the safety of leratractinib in these patients who had really long-term responses, and you can see here that these patients who had these incredibly long-term responses, none of the parameters have been reached. Median duration response is not reached, PFS has not been reached, or survival. We had in about several of these patients, particularly the pediatric patients, we had a wait and see period where 79% or 33 of those patients stopped actually the leratractinib. And of those um, who exited the first wait and see period, only 9 of those had progressive disease and resumed treatment with re-response. But many of these patients remained off study after this wait and see period and is still doing well. This is also a recent data set from ESMO looking at the real world experience of leratractinib in patients with TRK fusion. Overall, what you see here is that the response rates, duration response, median PFS are around the same as we saw with the leratractinib study that I just recently reported. Of note here, I think, and we'll talk a little bit more about this, is that the primary CNS tumors, albeit have a lower response rate overall than those patients who have disease outside of the CNS. Again, this is again the leratractinib again in the first line setting with NTRK. And again, we reported this recently at a meeting showing that those patients, even who have not gotten chemo, have significant benefit when they get these drugs in the first line setting. Again, both showing duration of response, PFS, and overall survival, all suggesting that these patients, if you are able to identify these patients in the frontline setting, may actually benefit even above standard therapy. There are other drugs beyond leratractinib. One is entrectinib, and as you can see, the response rates are like slightly lower. The median duration response and PFS are very similar in that regard. Again, showing that these drugs across different types of drugs have similar, very profound efficacy. The safety of these drugs are also very similar, albeit entrectinib has a little bit more of this dysgeusia than we anticipated. They also showed anemia. There was some dose reductions associated with entrectinib relative to leratractinib. We began developing or trying to understand what were the mechanisms of resistance with these new TRK inhibitors many years ago. And in fact, even before the end of the registration trials. And we discovered that, albeit that these drugs lasted for very long periods of time, there were patients who eventually developed resistance. And you can see here that there were really 3 mechanisms of resistance. One is what's called a solvent front mutation, gatekeeper mutation, and also off-target resistance mechanisms such as KRAS, MET, or IGF-1R. There have been drugs since then that have been developed for these mechanisms of resistance. Most recently, repotrectinib, which has been approved in NTRK fusion. It was initially developed primarily for ROS non-small cell lung and is also approved in that setting, but it is also known to be a very potent TRK inhibitor and can overcome particularly those solvent front and gatekeeper mutations. And you can see here, these are patients on NTRK with NTRK fusion who have had also profound efficacy from repotrectinib. And these are, again, patients who got repotrectinib who have these NTRK solvent front mutations. And you can see here that they continue to benefit even though that they have these resistant mutations from the first generation. Well, what about pediatric patients? Pediatric patients, even more so than adult patients, have profound benefit from these drugs. You can see here close to 86% response rates. Many of these patients, infantile fibrosarcoma, which usually is resistant to chemo, and some soft tissue sarcomas, they went into complete response, and some of them went into partial response and underwent resection and have remained in complete response. And as you can see here, the disease efficacy or response rates of these patients with these different tumor types. This is also data from entrectinib, and the AEs are very similar to that of adults. However, there are some additional adverse events that we need to be following with these patients on NTRK inhibitors. You can see here the majority of these AEs are, again, grade 1 to 2. Overall vomiting, some ALT, AST increases, etc. So in children, one of the things that we do have to look at is fractures, particularly with entrectinib, more so than larotrectinib. Larotrectinib data has been less problematic in the sense that in some patients with entrectinib, we don't fully understand the mechanism. There appears to be increased risk for fractures. In addition, in all TRK inhibitors, we are seeing two other side effects that it can occur both in adults and also children. One is weight gain. Again, as I shared with you, we weren't entirely clear when we were doing the early studies how much of this was related or just that their cancer was getting better. But we now know that likely because of TRK-B and its mechanism and how it controls appetite, etc., that weight gain is something that we do see with these TRK inhibitors. In addition, patients can also develop withdrawal pain if you stop these medications abruptly. And so we recommend that you slowly wean these drugs off these patients to prevent this withdrawal pain. What about patients with CNS? As I shared earlier, that the overall response rate is lower in patients with CNS metastasis or just primary CNS disease, than in patients with no CNS metastasis. And it's not that these drugs do not cross the blood-brain barrier. We do believe that they do, but it may just be the underlying biology of both CNS mets and also primary CNS. As you can see, in the primary CNS, only about 36% of these patients respond, albeit, it's a small number. And also, with many of these patients with high-grade glioma, 36% response rate is an amazing response rate. You can see here, we know that entrectinib initially from the outset was pursuing whether or not there could be efficacy across the blood-brain barrier, and you can see here that indeed it does. We now know also that larotrectinib also has efficacy across the blood-brain barrier, and you can see here that its efficacy in primary CNS and also in patients with CNS metastasis. Again, the response rate is around 37%. Overall, these patients still do well, but relative to the patients with non-primary CNS, not as well, but still, as you can see here, median duration response close to 17 months, PFS at 20, and overall survival is yet to be reached. And I think that's it. Well, thank you again for joining me on chapter 2 of this journey on NTRK. My hope is that many of you will really consider getting NGS, particularly RNA-based NGS, to identify these patients, because these patients will have incredible benefit from these trials. Thank you.
Hi, I'm Ted Leitch, a pediatric oncologist at the Children's Hospital of Philadelphia. And in this section, we're going to talk about the patient experience with TRK inhibitors. When I think about the patient experience, I remember one of the first patients I treated with a TRK inhibitor. This patient was an 11-year-old girl who had a chemotherapy refractory sarcoma and was actually on hospice at the time we identified the TRK fusion in her cancer. She came in and enrolled on a clinical trial of a TRK inhibitor and had an immediate response with essentially resolution of her pain within a couple weeks and resolution of her ascites. She was able to go back to school, have her colostomy reversed, and has now grown up and is actually an EMT taking care of other patients. So I think this highlights the profound impact these identification of these alterations and these therapies can have on our patients. I'd now like to show you a video of another adult patient who had a TRK fusion identified in his cancer.
I will never forget this day because in the morning I met the team of surgeons, and I remember the surgeon told me that it's not going to be a small surgery, it's going to be a very big surgery, exactly very similar to the previous one. They're going to take out my whole spleen, and also they're going to probably take out the tail of my pancreas. And I remember telling my brother that, I'm very disheartened because if it goes on like this, if my cancer keeps coming back, and every time I lose an organ, probably in 2 years I might not live. I don't want this kind of life. I was manifesting that I don't go through the surgery. And I remember when I went to the clinic, I kind of probed, and I remember the head of the clinic was this amazing senior doctor. He had empathy. He he asked me, and I gave him the whole history of this 1.5 years, and he kind of, and then I asked him that, look, I mean, I remember this current hospital, they took my, a sample of the tumor, and I'm still waiting for the results. And then suddenly my oncologist opened the laptop and found out that they finally discovered my type of cancer, which was the TRK3. And they all jumped in joy, and they said, and the senior oncologist said that, oh, there is one last line of treatment, and the drug, that there's a drug which can actually work, because he's used that drug for blood cancer and for lung cancer. And I was pretty emotional. I remember I cried, and and I didn't know how to react, because the senior oncologist said that you are the first one in UK to have this. Because I asked him, does this work for GIST? He said that we don't know, but we are sure it's going to work. I mean, he had the belief that it's going to work. So I feel that, if the testing or the genome testing, or, if the hospital could have known about the type of cancer earlier, because when after my surgery I was clean for 3 months, and then there was a relapse. I feel that had they known that my type was TRK3, probably it wouldn't have relapsed. Probably they have put me on medication and it wouldn't have come back. That's what I honestly feel. My quality of life has been affected in two ways. One is post surgery, my whole eating, the way I used to eat before my surgery was very different from now. I have a small stomach, so I eat, even if I'm hungry, I can't eat a lot of food at times. And also sometimes the food stays in my esophagus. So in the night, if I'm coughing, sometimes, the food comes up. Even last night it happened, and then I sit up. Sometimes it's frustrating because you sit up for a while and you try to sleep like that. That's one. But the second thing is also with this medicine, with this medicine, I'm happy that I'm getting the treatment, but also it has side effects like a lot of joint and muscle pain, constipation, hair loss. Sometimes you are dizzy. So you have to have a very healthy life. You like, I go to the gym, I'm working out, but I used to work out a lot. with a, I used to run. Now I can't run. I can't swim because I have to be very careful because I mean, they've cut me open and, there's stitch and I have to be very careful uh, about my eating, about how much physical activity I could do. Um, Sometimes I'm very anxious because of the medication and I can't sleep. So my quality of life has been affected, but I try to, make the best out of it. When you go and meet the oncologist, uh, you hope that the partnership actually builds and there's a human side and there's empathy, but uh, I haven't been fortunate enough to actually experience that. So yes, there is a lot of information out there, which I think you need to tap into, and that's how you understand, because there's a lot of research and there's a lot of But look, I mean, I think that I am doing it because I'm still young, but I wish that there would be more seminars, there would be more, patients coming together, interactions with doctors, that would really help because. Uh, I don't think that that's happening enough, honestly.
So I think some common themes that I've seen in patients when they identify these TRK fusions is that these can really have profound life-changing effects on our patients. Patients often feel very, very disheartened and don't want this kind of life, experiencing the pain and suffering of traditional cancer therapy. And when they identify a TRK fusion in their cancer, patients often become emotional. And this can actually feel like winning the lottery for some patients because they do have these other targeted therapy options that have fewer and different side effects than chemotherapy. These patients that we've discussed today really highlight the challenges in the diagnostic pathway. Some patients will have these NTRK fusions identified early in their treatment course, but others may not have these identified until late, and then may feel regret or disappointment that these weren't identified earlier and potentially spared some of the side effects of chemotherapy. To identify these NTRK fusions, it's really important that we have interprofessional collaboration and that we work closely as oncologists with our pathologists and molecular diagnostic labs to understand which patients should be tested, and then to get the appropriate testing that can correctly identify these alterations in their tumors. Many of our patients will express similar feelings as was expressed on the video, that there are side effects of these TRK inhibitor therapies, but many of them are more mild than we see with traditional chemotherapy, things like increases in liver function tests and mild neutropenia. Some adults and children less commonly will also experience dizziness or other neurologic effects. But in general, my experience is that patients feel much better quality of life on these types of therapies than they do on traditional chemotherapy, which often results in significant complications that may require hospitalization or feeding tubes or other side effects. I think it's important that we work closely with nurses and other specialists to help our patients adapt to the need for these therapies and really ensure that they are able to be compliant with these treatments. These, as opposed to most other agents, are oral daily medications. And so that can be a life-changing experience, especially for children who have otherwise been healthy. And so working with our nurses and psychologists and social workers to ensure that patients have the resources they need to be compliant and be successful is really key. So I hope this session has been really helpful for you. It's unique that we're focusing really on the patient experience. Many of these educational sessions have not focused as much on this, but I think it is so impactful, the impact that testing for TRK fusions and other targetable molecular alterations can have in our patient's journey, and the impact that these therapies can have on their treatment. So I want to thank you again for joining this session, and really appreciate your attention. Thank you.